way 114, it's gonna be the exact same way in 211. It's just perfusion is a complex concept. You do, I promise. It's the most complex. So, infection's really easy to understand. Wash your hands, get you'll know. Okay. Keep everything close. Perfusion is just a lot more going on. So this Kahoot, it's only got 2 questions, but we're gonna go back and forth between this and the PowerPoint. The overview one, this one. So we're gonna go back and forth and kind of answer some questions. Go to the PowerPoint for a few minutes and then come back. So a big thing with this particular perfusion module is that it is very wide and varied. Like there are a lot of concepts in here. We are going to be talking about the electrical system of the heart, the perfusion of the heart, so that's the heart muscle itself, and then the contractility and the actual heart flow through the body. So that is 3 separate, do you hear me? Separate functions that produce 3 different sets of symptoms, problems, things like that. Yes, they can have some crossover and cause other problems, but 3 separate issues. Electrical system, the flow through the body, and then the actual perfusion of the heart muscle itself. Okay, and we have exemplars for each one of those things. A lot of our concepts that we're going to go over in 114 are going to be gone over again in 211. Like we have basic dysrhythmias, 211 has advanced dysrhythmias. We have basic heart failure, 211 has advanced heart failure. So everything you learned in this module, you're going to have to take with you to 211 as well. So you're just going to build on the same concepts. So that's why I gave us some extra time rather than cutting today off because it'll still y'all need practice, 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 practice. All right, y'all ready to start Kahoots? Yes, I'm ready.
Paper, if you want me, I forgot my number.
Overview. Alright, A and P question to start us off.
Good, Tara.
All right, so let's do some review. We're gonna say it's early in the morning, folks. We gotta wake our brains up. So I said, we've gotta know the perfusion throughout the body. So when we get into heart failure, if you don't know where things go from right and left, you're gonna get heart failure completely mixed up. So, I think I've got a video for Khan Academy that kind of goes through it again, but, all the AI things can walk you through this. But let's walk through it really quick. If you have blood in your hands and your feet, they are out in the furthest extremities of your body. They get pumped to where? Okay, even before we get there, let's start a little bit.
Superior and inferior
We
vena
go to
cava.
the inferior and the superior vena cava. So we're coming all back to the vena cava. That's actually where your central lines go. So we're gonna come back to the vena cava. Then we're gonna go where? We're going to the right atrium. From the right atrium, we go to the down to the right ventricle. So the right atria is going to contract while the right ventricle is relaxed. So it's going to be pumping that blood down into the ventricle. And then once it pumps, where does it go from the right ventricle? It goes out to the pulmonary system, goes out to the lungs, where there it gets oxygenated, goes through tiny little capillary beds. That's going to be important later on with one of our exemplars. Goes through all those tiny little capillary beds to get oxygenated, comes back to the left atrium, and then goes to the, so your heart's doing like this, pumping kind of opposites, and then we're going to the left ventricle, then where? To the aorta, which again will be important, because then it goes to the rest of your body. Alright, so everything moves forward. Everything moves forward. When we're dealing with heart failure, we're having a problem with the heart struggling to push things forward. So when we have heart failure, we have issues of blood backing up. So that's why why it's very, very important if you have right-sided heart failure, if you have left-sided heart failure, that you know where forward is and where we just came from. So when we get to heart failure, we're gonna be going back over that a lot. Okay, so you gotta know the blood flow through the heart. Well, everywhere. All right, so this question is referring specifically to the coronary arteries. So your heart gets perfused on the outside. The blood that's sitting inside of your atrium and your ventricles do not perfuse your heart. Those are just holding vessels, like a bladder. It's just holding the blood. So your actual heart perfusion is on the outside. So if we look at our little picture here, these are your coronary arteries on the outside of the heart. So when your heart contracts, so when you have systole, your heart contracts and it's going to push all that blood out into the aorta, right, to go to the rest of the body. So all of your body gets perfused during contraction, during systole. So with your heart, we're going to contract, push all that blood out of the atria. It's got this nice little hook right here. So when your heart relaxes, all that blood that didn't quite make the little loop over there is going to passively backflow and perfuse your heart. So your heart actually is passively perfused. It's getting perfused when it is relaxed. So all the blood that didn't make that pump is just going to flow back down like a river and perfuse your heart. So it's very, very important that we have good relaxed time when our heart beats so that it can get perfused. So that'll come into play with a lot of our different exemplars when we talk about heart rhythms, making sure that we have good relaxed time. When we talk about these vessels, making sure we have good relaxed time. Your blood pressure, all those things are going to matter. All right, vocabulary. Close. Close. All right, so most of the time we have arterio and atherosclerosis together. So a lot of times they get just kind of thrown together and you kind of just pick one word or the other in your meaning book. So we actually treat these a little bit differently, so I want to make sure that we're separating it out. So arteriosclerosis, that is where the vessels are just tight and narrowed out, like they're constricted down. Athero, so adding that little TH, that means we have plaque buildup on the inside. So arterio is going to be more like your patients with diabetes that are like contracted down, patients with high blood pressure that their vessels are contracted down. And then atherosclerosis is going to be that plaque buildup, so that cholesterol, your LDLs, your triglycerides, all of those things. So we treat them a little bit differently. Arteriosclerosis, we're going to work on dilating out the vessels. So our medicines are, like our beta blockers and things like that, opening up the vessels. Whereas atherosclerosis is going to work on the plaque. So what medicine would we do with that? The statins to try and decrease that plaque buildup. And if we do have both of those things going on, then we usually go to like a blood thinner to try and get through that narrow passageway easier. So they have a little bit different meaning, but like I said, a lot of times people just put them together and just pick one and just use that, because most time we have them at the same time. Thank y'all for not choosing either one of the other two. usually gets at least one person jumping on the this first. It just sounds good, right? All right, more vocabulary. Very good job. So most people got that one right. All right, so preload. That is going to be the volume. Did we hear that word? Volume, 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 volume. Preload is a volume of what is coming to the right atrium. So it's all the blood volume from my arms, my legs, my extremities coming back to the right atrium. So when you read various medications, it'll say it decreases preload. That's what we're talking about, the volume. So if you think of what drug class will decrease a volume, what do you think of? Diuretics, because it's going to affect our volume. If we give a fluid bolus, we are going to increase our preload. So we're going to talk about preload, and we've got some more loads in a minute there. So when we talk about preload, we're talking about volume, and I can affect that with diuretics, and I can affect that with fluid boluses. Dehydration takes a big part with your preload. Fluid volume overload, like with our renal failure patients, they've got too much preload. So preload is the volume coming back to your heart. When we talk about congestive heart failure, we will talk about preload. Didn't quite get everybody. All right, so afterload is the force, or if you want to think of it as the pressure, that the ventricles have to overcome to push blood through the heart valves. So we've got right and left sides, so we've got two different types of afterload. So let me pull up my picture and look at preload and afterload real quick. We'll make it bigger. All right, so we said preload, that is a volume. So you see he's got a bucket dumping into the right atrium. So we're dumping in a volume for preload. We said it's increased in hypervolemia. Don't worry about, we're not covering anything with heart valves in 114. Heart valves is all 211. Okay, so if you get into your reading, you start getting into heart valves, that's 211 content. We're sticking with the basics with heart failure, rhythms, and coronary artery disease. We're also not doing heart attacks, which is really hard to do coronary artery disease and not heart attacks, but we're gonna try. It's hard. Anyways, okay. Afterload, you see he's got that little vise on the vessel coming out of there. So afterload is a resistance, it's a pressure, it's a force that your ventricles have to overcome in order to push the blood out of the ventricles. Afterload is extremely important that we find that right balance. You can't have too much afterload, because if you have too much afterload, so if that vise is really, really tight, that heart muscle is going to have to do what? It's going to have to work really, really hard to overcome it. Because guess what it's going to do? Overcome it. It will. But then your heart muscle ends up getting overworked, overstretched, and then it eventually fails later on in life. So we are going to overcome that pressure. We just don't want to overwork our heart to do it. So this would be stuff like hypertension, high blood pressure. Yes, pretty much. Vasoconstriction. All right, we also have to have a good amount of afterload because remember what we said with how your coronary arteries get perfused. If you don't have enough afterload pushing that pressure back down, your coronary arteries aren't gonna get perfused. If it's just a wide open door and all the blood can go, there's no blood left over to come back and passively perfuse your heart. So if we have hypotension, so we don't have enough pressure coming back, our heart doesn't get perfused. So we've got to strike the right balance of afterload. Got to have enough to perfuse our heart. Can't have too much or we're going to overwork it and you're going to end up with a heart that fails later in life. Okay, so preload volume, afterload pressure. When you're reading about your medications, like start noticing those terms and how that affects workload of your heart, okay? Because I know before it was just kind of like, oh, those are some words, moving on.
Did you just say having not enough of afterload causes hypertension?
No, so
Or just
if
the
we
whole
don't have enough afterload, our coronary arteries aren't gonna get perfused. Because all that blood's just gonna go whee and go over the hump, and then there's
Yes.
nothing left to come back down.
Oh, the hypotension.
Hypotension.
And then too much hypertension. Got it.
Gotta have the right amount of tension, not hypo. Like you want to. More vocab. Man, I just keep getting y'all. Just keep getting y'all. Get ready with good words. Just can't resist. All right. The term that is the amount of blood, so I'm looking for a volume because it's the amount of blood ejected with the ventricles with each heartbeat. So this is your stroke volume, which is your amount. Now, I am not going to hate on those of y'all that chose ejection fraction because that is the percentage of how much comes out with each heartbeat. So when your heart beats, does it eject every single bit of blood that's in it? No, it does not. It always holds on to a reserve. So there's always a residual. So if I say the word residual, what does that mean? It's like what's left over. So you have residual air that stays in your lungs. You have residual blood that stays in your heart. You have residual food and fluid that stays in your stomach before it's emptied out. So residual is just leftover. So there's always going to be a little bit left over in your heart. So stroke volume is the amount, like the actual volume that comes out. Ejection fraction is the percentage of blood that comes out. Before I answer my next question, I'm gonna go ahead and ask it. I want you to answer it. Yay! I was hoping that would be done, right?
Just a guess. There's no.
Well, that was a good guess. 70% is our goal. We want a 70% ejection fraction. Making sure I'm covering all the things. So we want 70% is our goal. We'll talk more about how we find that out in a minute. Anything less than 50% is gonna be pretty much good heart failure. So we want at least 50%. So less than 50%, we know our heart is not working to the optimum capability that it can. We don't get above 70%, it's just not a thing. So, you know, it's not saying your heart's great. If you get 100, that's bad. It just doesn't work that way. So we want around 70%, anything less than 50, heart's not working very well. Anybody would just be mad at y'all. Thank y'all, because if y'all did bad, I was so gonna snap a picture and send it to Bridget. It's a very good stroke volume times heart rate. That sounds like a great question for math. Super easy question for math that you might see later. So cardiac output, calculated stroke volume times heart rate. Not answer the next question. So about to say, what should it be? Very good job. So around 6 is kind of the average, 6 liters per minute. Make sure when you are doing your math that you are looking at your units of measure. Am I asking you for milliliters per minute? Am I asking you for liters per minute? So make sure you're looking at your unit of measure when you see it. So if this was in milliliters per minute, that would be a much different number, wouldn't it? Much different number. So just make sure you're paying attention to your unit of measure, because I have a lot of these questions, and some of my questions ask for milliliters per minute, some of them ask for liters per minute. So I don't know which one I'm gonna pull for y'all, because I'll just go through it, I'm like, yep, that one looks good, that one looks good. So I may pull a milliliter, I may pull a liter, so just make sure you're looking out for the unit of measure. So stroke volume times your heart rate. So if your heart rate is really high, your stroke volume is going to be low because you don't have enough fill time. If your heart rate is very low, you've got plenty of fill time, but you just don't have that good multiplier. So either way, if your heart rate's really high or your heart rate is really low, it's going to decrease your cardiac output. So we've either got to have good fill time or we've got to have a good heart rate in order to have good cardiac output. So we're going to do us a nice good care plan on cardiac output because it's going to affect all of our exemplars that we have. And I got one more question. I wonder if you're going to get dethroned. And answer this. Hit. Very good job. So we're asking how the heart handles increased workload. We're gonna go over all these tests, but the stress test, we're gonna put the heart under stress and see how it does. So it's how it evaluates how it handles workload. See the winner here. Fast thinkers. Fast thinkers. Good job, good job. Okay, what was your question?
Oh, I just wanted to ask about the cardiac output when you were talking about the relationship, so like, they're like inverse? Is that what you said?
So, not really. So, we'll kind of go through it like with each example that we give. So if your heart rate's really high, you don't have enough fill time, so then your stroke volume would be low. But if you have plenty of fill time, but your heart rate's really low, then your heart rate's really low. So as we kind of go through different scenarios, we'll talk about how it affects your cardiac output, so we can actually see it and understand it a little bit better. I know when I'm saying it, it's like, what? It's better when you see it like in examples. So don't do an example, remind me when we get to different scenarios.
So with the low heart rate, you have a high stroke volume, meaning you have a lot of fill time.
So the heart only holds so much. it can't, just cause your heart rate's low doesn't mean it just keeps getting more and more and more blood volume. It's gonna get the same amount of volume. So your stroke volume somewhere around 60 to 100, it's never gonna go above 100. So if your heart rate's really low, your cardiac output's gonna be low. Like I said, we're gonna go through, like each kind of example that we have, we're gonna go through and show how it affects that flow. Okay, so we'll practice it throughout our time. Alright, so let's go to our PowerPoint because we didn't quite get all of these terms, so let's make sure that we know all of the terms. And then we're gonna get into those diagnostic tests, because our last question was just on diagnostic tests. So we're gonna talk about pre-procedure and post-procedure, like what's the role of the nurse for each one of these tests, because a lot of these tests you've probably already seen if you've been to the cath lab. So we'll kind of go over, and you guys can kind of tell me what you saw in the cath lab, what you got to help with. Because y'all got to go in pre and post, right? Pre-procedure and post-procedure. Okay, good. So y'all be able to tell me more about what you learned. Okay, so the coronary arteries. So before we move on from this slide, let's just kind of talk about the coronary arteries just a little bit. So this is what you guys probably heard them talking about in the cath lab because they're actually looking at these vessels. So we've got the right coronary artery going down one side. Pretty much about it over on the right side. We don't have quite as much perfusion going to the right side as we do the left, because the left is what's pumping blood out to your whole body. So the left, by far, is more important. It gets a lot more vasculature going to it. So you've got the left coronary artery coming out, and I'm not going to ask you specific questions about where these arteries are, so don't freak out about trying to memorize all of that. But the left coronary artery bifurcates into a lot of other arteries. So if y'all heard the term widowmaker, that's it. So the left coronary artery, the one coming right off the aorta, because it bifurcates into a lot of different vessels. So if you get a blood clot or like a vasospasm or a clamp down in that right there, your whole left side gets no blood. That's how people drop dead of heart attacks suddenly, because that's called the widowmaker. It's going to go into the circumflex, which goes around the back of the heart. The left anterior descending, or the LAD, is going to come around to the front side of that left ventricle. So we just get a lot of perfusion, a lot of attention on that left side. And these vessels are filled during systole or diastole. Diastole, so we gotta have that good rest time so that they can passively fill. They also need to be open. They do not need to have arterio or atherosclerosis because they're being filled passively. So if it's got a lot of narrowing, it's not like there's some big force pushing blood through behind it. Like they're passively being filled. So if they're narrowed, they're not going to get good perfusion. That's why we have to send people to the cath lab all the time, get these vessels opened up so that they get better perfusion, because they are passively being filled. We talked about preload and afterload. Preload is a volume. So we affect that with fluid status, diuretics, things like that. Afterload is a pressure. So we affect afterload with things like vasodilators, beta blockers, antihypertensives. All right, so terms, we got most of these, but let's get the rest of them. I want to make sure I don't say anything else about preload and afterload. All right, cool. Cardiac output, we talked about it's the heart rate times the stroke volume. I don't have cardiac index on here, but what's cardiac index? Craig, I need the sound on my heart. All right, so cardiac index is just your cardiac output adjusted for your weight. Oh, you said it so wisely. All right, so it's adjusted for your BMI, adjusted for your weight. So we have flow tracks now in the ICUs. It's really cool. So when you go to ICU clinical next semester, you can actually see we have output and cardiac index that we monitor on our patients continuously. Pretty cool. So cardiac output, heart rate times stroke volume, cardiac index adjusted for BMI. Compliance. What does compliance sound like? Do what you're supposed to do, right? Compliant. Your heart is supposed to open and stretch, fill with blood. And so that's what compliance is. It opens and allows volume in. It's nice and compliant. It opens as it's supposed to. Where we get decreased compliance is where those heart walls get very stiff and they don't open as they should. So when your heart gets overworked over a period of time, whereas it should open to receive blood, if your heart muscle's overworked, it's just like, and it doesn't want to open to get the blood volume it receives. So compliance means our heart opens easily. So you may have heard that term in the cath lab when they were talking about the ventricle compliance. Contractility is what? Yeah, closing it back up. So contractility, how good does it contract? So the Starling law, you don't have to know the name of that, but I'm telling it to you, so when you read it, you'll know what I'm talking about. So the Starling law states that when something stretches, it returns to its previous shape. So it's also called the rubber band law. So if you have a rubber band and you stretch it out and then you let go, what happens to the rubber band? It snaps back to its original shape. If you keep stretching and overstretch that rubber band, what happens to it? It loses its original shape and then it's just kind of big and blocky. So contractility is how well does that heart muscle return back to its original shape and pump that blood out. So again, when you overwork the heart muscle, what does it do? So cardiomyopathy actually affects the compliance because it doesn't allow it to open, to accept blood. When we overwork it, so a lot of things can happen when we overwork the heart. The other thing that can happen is it's like that stretched out rubber band. So it stretches out and then it just stays wide open and its contraction is like we should be. Contract blood out. So if we overwork and overstretch it, then it just goes, and that's it. And we don't get a whole lot of blood going out. So we don't get good stroke volume. So we don't have good cardiac output. So our contractility is how well does it go back. All right, ejection fraction, we already talked about that. So that's the percentage of blood. What's the normal ejection fraction? 50 to 70. A heart murmur. So going back to assessment. What does a heart murmur sound like? Not quite a tick. That would be an artificial heart valve.
Not a click.
Nope, not a click. So it's another, describe a heart murmur in a different way. A whooshing sound. Yeah, so like whoosh. So you should hear lobed up, right? Those valves closing nice and tight. You should not hear low. You shouldn't hear that. So for a heart murmur, you're going to get more of that in 211. So for me, I just want us to know that if your patient does not have a heart murmur and suddenly develops a heart murmur, we've got problems. Okay? We've got problems. That's why it's very important to be listening to your patient's heart sounds every shift, because you can develop heart murmurs, especially if your fluid volume overloaded to where your heart's just struggling with all of the volume that it's getting. If your heart becomes overworked and it can't push all the blood out and the valves kind of start failing on us. So we're just kind of looking out for a new heart murmur. You should get a baseline in the morning with your assessment. If you hear a heart murmur, so in clinical, if I ever hear a heart murmur, my first thing I do is to go back on the report and find out, was it there before? And if the previous nurse says, I don't know, we go in the chart to look and see, do you have a heart murmur? Ask the patient, do you have a heart murmur? And if nobody says anything about a heart murmur, I'm calling somebody and going, hey, will you come listen to this person? So it depends on which valve you actually have the murmur in. So because you've got all the different valves in your heart between the right atrium, the starting to die. Can it be revived? Yes, it can. Ischemia can be reversed. So if we start to develop ischemia and tissue starts to die, it hurts. It's very painful. So our goal is to restore oxygenation, restore perfusion to that tissue so that it doesn't completely die. What's the term if it completely dies and we can't get it back? Necrosis. So we're trying to prevent necrosis. All right, we talked about preload, we talked about stroke volume, so the only two left is pulmonary and systemic vascular resistance. These are both very specific afterloads. So one of them your right ventricle has to overcome, one of them your left ventricle has to overcome. So I'm going to ask, which one does your right ventricle have to overcome? Which is the afterload for the right ventricle? Pulmonary vascular resistance. So that means the left ventricle's afterload is more specifically called the systemic vascular resistance. That's also on our flow track. We can monitor. We don't monitor the pulmonary because that's real. You gotta have some real invasive things to get. We can monitor the systemic because that's mainly like your blood pressure. So our flow tracks can tell us cardiac output and it can tell us your SVR.
Pulmonary is right ventricle's afterload. Systemic is left.
Because that goes back to when the right ventricle pumps out, where does it go? To the lungs. Okay. When the left pumps out, it goes to the body. All right, let's talk about some diagnostic tests. So what kind of serum lab work do you want to evaluate heart? Troponin. All right, so there are two different things. So did you say D numbers? So it's more about clotting type issues. So we're going to kind of put a little star on that. Here, we'll come back. What is that? Troponin? Heard that. All right, troponin. Yep. Tell me some more tests that kind of go with the troponin.
Oh, sorry.
All right, CKMB. So CKMB and a troponin are like this. Like they're telling us basically the same thing. So a troponin and CKMB. So CK, the MB stands for myocardial bands. I have to slow down before I say that because I always say the wrong word first. All right, so myocardial bands. So CKMB and troponin go like this. What should your levels be? Very good answer. Normal. What would normal be? You should not have troponin or CKMB floating around in your bloodstream. Because what do those tests show? What's the purpose of those tests?
Cardiac damage.
It shows cardiac damage. So it shows us more specifically, if we use our words, ischemia. It's telling us that some cardiac muscle is experiencing some ischemia, so the muscle starts releasing this enzyme in response to that. So your troponin and your CKMB elevate because heart muscle is dying. Correct. We want those less than 0 or less than 1. We don't want any of it in our body. Now, we're going to get a little bit of it because, I don't know about y'all, but these stairs are destroy me. So if you run a whole bunch of stairs and you may have a little touch of troponin or CKMB because your heart went with that. Like you're working it hard and it's like, I don't have enough oxygen. Your supply is not matching your demand. So we can get a touch of elevation when we have sustained tachycardia, but it should resolve. So another big important thing with troponin and CKMB is they are a delayed elevation. It's delayed. They may not elevate for several hours. Now there's some real specifics on both of those, and I don't care that y'all know the detail on the hour time frame. Like CKMB elevates at this hour, troponin elevates at this hour. Don't worry about that because we just want to know it's are sitting in a hospital room, like you're already a patient, and you start complaining of chest pain, we're immediately gonna draw blood, aren't we? Well, that blood value may be normal, because they don't have time for it to elevate yet. 8 hours later, we're gonna redraw those. They may be elevated at that time. So we always wanna draw troponins and CKMBs, like serial lab draws. So we're gonna do it like every 6 hours or every 8 hours times 2 or 3 draws. Because we wanna see it peak, and then we wanna see it start trending down. So which is really fun when your lab calls you to say, you have a troponin of 50. Well, it was 70 8 hours ago, so yay. The lab's freaking out because it's troponin of 50. Well, you gotta look at what was it last time you drew it. So we're looking for a trend. We're looking for it to peak and then come back down. We would also draw those levels for any new development, like the patient starts getting more chest pain. We're gonna draw them again and see if they're on a downward trend or they going back up. All right, so troponin and CKMB. Those are damage to the heart muscle. Now we could draw myoglobins and just a CK. Why would I draw a myoglobin and a CK to go along with those? Because what do those measure? Alright, so we said troponin, CKMB is your cardiac muscle damage. Myoglobin and CK is just skeletal muscle damage. So we may draw that as like our control. So we have something to compare it to.
Say it one more time, please.
So myoglobin and CK, we may draw those along with troponins and CKMBs, because those would be your control. So am I having muscle damage over my whole body? Or is it specific to the heart? So did y'all learn about rhabdo? No? Sometimes y'all know about it, sometimes y'all don't. Depends on how deep y'all make Ms. Bridges go with this stuff.
For summer semester.
That's true, y'all were summer semester. Yeah. So, I won't even go there. I won't go there. We'll leave it alone. If you really wanna know, you can ask me. So, we just run those as controls. It's like a comparison. Is it whole muscle damage to your whole body, or is it like limited to the heart? So if my myoglobins are normal, my troponins are through the roof, I know it's just my heart. If they're both elevated, well, I got some major oxygenation perfusion issues on my whole body. It's not just my heart. Okay, so those kind of are controls. What else you want to know for cardiac, for the serum lab draws? BNP. All right, so let's go ahead and put both of these up here. So we have 2 different lab draws. Because in medical world, we would like to make all of this confusing. Congratulations, because we actually want both of these. So let's do the one we know. What is this? This is a metabolic panel. What all am I going to get here? Electrolytes. Is that important to know for my heart? Absolutely. I need to know my potassium, my calcium. I need to know all those things for my heart. So this is important. The NP stands for what? Help me out. I don't want to misspell this when I'm writing it up here.
RIU.
It's natriuretic, but it's, I don't know how to spell the natriuretic.
RIU.
It's IURET. Look, there's too many vowels right here. Too many vowels. I'm gonna put the I before the U or the R and the E. There you go. Brain natriuretic peptide. All right, what's that?
What kind of tracks? Like how long it tracks your heart?
All right, this one is gonna tell me a lot about my heart's contractility. It was named for something else, and then they realized that they got more value out of this lab with the heart. cardiac lab. What else you want?
Get the CBC, just from that one out there.
CBC's helpful, cause what can that, what can that tell me? Yeah, your H and H, cause that's gonna help me know about my preload, right? Cause I need that volume of blood, so that helps me know a little bit more about my preload. So CBC would be good for that H and H, as well as my platelets, because I don't need them all clumping up together if I've got too many of them, or I don't need you bleeding out because I ain't got enough of them. That'd be helpful. What else? How am I gonna know if I've got plaque buildup? There we go, triglycerides, cholesterol, LDLs, HDLs, all of those good tests. So I need all those tests to find out about my heart. Those all have their normal values. You should have a specific amount of each one of those. So I'll give those values to you on a test. You don't have to memorize them. One more triglycerides, but anything else show up? Electrolytes? So that pretty much gets most of, if we want to throw in like clotting factors and those types of things, you can maybe throw those in. But for the most part, that's a lot of my serum lab draw that I'm good with. All right, stress test. Let's talk about what a stress test is, and then we'll go on our break. So cardiac stress test, this test, we had our question on it. What does it evaluate for us? How does your heart function under stress? How does it handle increased workload? So this gentleman on here is having a stress test. We typically do this on a treadmill. However, there are lots of people that are not able to get up on a treadmill for various health and mobility issues. So we can do this medication-based. I don't care that y'all know the medications, because literally the only time those medicines are given are for this test. But they can simulate, basically by increasing the heart rate, they can simulate some stress. So we don't have to get them up on a treadmill. But this is the preferred way, is we're gonna get them up on a treadmill. We're gonna hook them up to a 12-lead EKG, which we'll get into today. We'll learn more about EKG stuff. They're gonna hook them up to the blood pressure, the O2 sat monitor, and they're gonna watch the heart rhythm and watch all the vital signs as he is on the treadmill. Usually it's a 20-minute test, and they gradually step up how fast the treadmill's going. They just evaluate how you do. So, why, if you were the nurse that's monitoring the stress test, what would make you stop the test because the heart is not handling this workload? What would make you stop it?
Their heart rate significantly drops.
Okay, so typically their heart rate doesn't drop. Typically, it's gonna go up. So we're gonna, based on their baseline, like whatever they come in, like if their heart rate's 80, then it's usually, they'll do a little calculation, like 20 or 30% above your baseline. We're gonna say that's too much of a tachycardia, so stop. So based on their baseline, if their heart rate goes up percentage-wise too high, we're gonna stop. Okay, so significant tachycardia, stop. What else? What'd you say? Is that what you suggested? Okay.
Blood
Why else
pressure.
should we stop?
Blood pressure.
Okay, if blood pressure drops, meaning the heart can't get enough perfusion out, we're gonna stop. Same thing if it goes up too high from the baseline. Like if I've got a certain percentage I'm allowing it to go, if it goes up too high, we'll stop it as well. But if it drops, we definitely gonna stop it, because I don't want anybody passing out on the treadmill. That would be bad. What else?
Chest pain.
Any type of chest pain, stop. Yeah, because that's definitely telling me their heart can't handle the workload. Any chest pain. What else? All right, if they get significant shortness of breath, and if their O2 sat drops, because we should not have an O2 sat drop with exertion from a cardiac perspective. Now, if they got COPD or some other things, we have to adjust for baseline. But we should not not have significant shortness of breath with O2 syndrome. One more thing. Okay, so I'm gonna tag on, so we've got the symptoms of feeling lightheaded, like we're gonna pass out. That's usually related to the low blood pressure. So let's kind of tack that together. Like they start getting symptomatic of a low blood pressure, which is the lightheaded and dizzy. All right, but I got one more like objective, almost stop. Arrhythmias, because I've got him hooked up to a 12 lead EKG. So if he starts showing me any type of changes to his rhythm, the only thing that should happen on the stress test is his heart rate should go up, because that's what happens when you exercise. It should not change from one rhythm to another rhythm. Shouldn't happen. Should not have EKG changes.
How fast are they?
It depends on the person, like what they can tolerate.
All things like.
They're not running like football players. Like, it's just a normal increase in workload. So we do stress tests for anybody that's gonna get short of breath, like if you can't walk from here out to your car without getting short of breath, like we wanna do a stress test and actually see what's happening, what's going on. So this is like a first step test. Pre-procedure, there's really not much for this. You know, they don't want a meeting a few hours before the test. It's not like you gotta be NPO at midnight or anything. Just, you know, limit what you eat a few hours before. Post-procedure, as long as everything goes well, you're just like, have a nice day, bye. And not really much anything pre and post-procedure. For a stress test, it's mainly monitoring during procedure, make sure they don't get in danger. So we're always gonna have our emergency equipment, you know, crash cart, things like that around in case